All right, you're welcome back, and you're still watching Good Morning Nigeria. Now, to kickstart our conversation for the topic access to NHIS this morning, here is a Vox Pop on a release experience about the scheme, and it has been put together by Oyeyemi Ajayi.
Yes, I feel it's working. At the same time, you know, the program needs to be comprehensive. What do I mean by that? You know, once you go to the NHIS accredited, hospitals now, the services they provide is usually minimal. It's not usually comprehensive. They'll just give you malarial and typhoid drugs. And when it comes to bigger health problems or challenges like eyes or teeth, like as I'm talking to you now, I'm having challenges with my teeth, and the doctor just told me go and get toothpaste. You understand? So the problem, that scheme is not really comprehensive. You understand? Eyes, teeth, other sensitive parts of the body.
For me, I'm a beneficiary of NHIS. And I have seen a lot of people, as also a medical practitioner, benefit from it. It is working. I am really happy about the progress so far. That some people have been incorporated. It's not just those that are government staff or those that are working for government, civil servants that are having access to the health facility, but individuals. But it can still be better. The level we are now, we are progressing, but we need to do better. We need to do a little coverage into the rural area. These are the people that need these facilities more than the rich. The poor, people are dying. They don't have money to go to the hospital. These are the people that really need a lot of, what will I call it? A lot of compensation with health services.
To me, it's not working as it's supposed to work. Because you go to the hospital, you ask for drugs, they will tell you some of the drugs are not covered under NHIS, so it doesn't make it work at all. And sometimes they serve the way they address you, it's not making sense at all. The way forward is to make sure all the drugs are covered by NHIS, because like we that are staff, that they're getting money from our salaries, and we hardly go to hospitals. Each time we go to hospital, they make sure what we want, we get it.
All right, we'd like to thank the respondents there to the Vox Pop conducted by our correspondent. With us here in the studios now to discuss this issue in further detail, let's welcome Professor Mohammed Nasri Sambo. He's the Executive Secretary of the NHIS, that's the National Health Insurance Scheme. Professor Sambo, pleasure to have you with us on the program.
Good morning, viewers.
Also here with us in the studios is Dr. Kolawole Owoka, who's Managing Director and CEO, United Healthcare International, one of the health maintenance, is it HMO? HMO, is it maintenance or management? Maintenance organizations, that's right. Thank you very much, Dr. Walker. Pleasure to have you with us on the program this morning.
Thank you for having me.
Last but not the least, Dr. Philip Ekpe is Managing Director, Ianya General Hospital, and is the chairman of the Nigerian Medical Association, NMA, FCT chapter. Dr. Ekpe, a pleasure to have you with us on the program.
Thank you, sir.
Okay, now you just listened to the comments by a cross-section of Nigerians with regard to what they think the NHIS is doing and how it is doing. What's your reaction in the first instance, Professor Sambo?
Good morning, viewers. Let me thank you very much for bringing me to this very important station to discuss issues that borders on the National Health Insurance Scheme. National Health Insurance Scheme is a scheme established by the government of the Federal Republic of Nigeria in 1999 through then a Decree 35 to principally assist people in curbing financial hardship in settling medical bills. Because it has been observed that many people have no access to healthcare delivery system, and the healthcare delivery system occupy the highest pinnacle in the development agenda of any nation. Health is wealth, And a healthy nation is a wealthy nation. Any country that has not been able to provide healthcare services to its people, that country is not worth to be a country. A lot of effort has been put in place to ensure the establishment of the National Health Insurance Scheme. I need to trace the history so that so that we can put the context in proper perspective. As a result of difficulty of getting healthcare by the people of Nigeria, it was recognized that there is need to have other multiple of healthcare financing options. Hitherto, the financing of healthcare delivery system was largely on the federal government or state government or local government. But it was recognized that government will not be able to finance the healthcare delivery system. That is why health insurance is introduced. The health insurance is introduced based on the principle of social justice and solidarity. Because if healthcare financing is largely driven through budgeting, whereby money is being expended to build hospital, to employ staff, and to supply drugs, only for people to go to seek for the healthcare and will not have access to the healthcare. That is why other options of healthcare financing came into being, that will allow for pooling of resources and pooling of risk. Once people are organized in that kind of solidarity, there is no question of people going to seek for healthcare, and the health system will say there is no drug.
Yeah, but you listen to the comments of Nigerians speaking a while ago, and that some persons will say that the views that they expressed are almost clearly representative of the experience of persons who are supposed to be beneficiaries under the NHIS. What's your reaction to those comments?
Yeah. It is true that people will have a complaint in the process of getting healthcare delivery services, going through the evolutionary processes of the establishment of the National Health Insurance Scheme. The National Health Insurance Scheme law was crafted in a way initially to allow pooling of resources, where you have a very buoyant fund that will allow sharing of risks and sharing of resources. But if you look at the beginning of the National Health Insurance Scheme, the law was not made compulsory. Okay. And many states actors and organized private sectors that are supposed to join the National Health Insurance Scheme refused to. Okay. So it was only allowed for federal government employees to join the National Health Insurance Scheme. And if you look at the whole principle why we are talking about pooling, you have a vast resources in the organized private sector, which is supposed to come together. And when you have a scheme whereby the only beneficiaries are federal government employees, and you look at the salary of the federal government employees, which is pooled, and is expected a proportion of the salary, it is said that 10% of the total of the basic salary, and 5% to be paid by the employers, 5% to be paid by employee. With the Nigerian minimum wage, the 10% of 18,000 naira is 1,800. And this 1,800 is what is pooled for people at entry level. Then you get the 10% of the people at the higher level, and you pool them together. And when you look at the nature of the workforce in Nigeria, it is supposed to be a pyramidal, whereby you have large chunk of the population at the base. So if you pool the resources, the 10% and the 5% from the employees, and you now say that this is the money that is supposed to be used to provide all the services that patients will require, then we are missing the point. The question is, you need to do an actuarial determination of what premium should be contributed by every prospective enrollee for him to be able to benefit from the kind of services that can be paid for by that amount of money. So the health insurance system rely on the credible actuary, whereby the risk and the benefit that should be accrued from the risk and the contribution will be determined. And the more you have the money within the system, the more you have a wide range of benefit package to be covered. And the less you have the money, the less the benefit package to be covered. So if you are talking about the principle of number, whereby only the staff of the federal government will be limited in the health insurance fund, we will not be able to have that sufficient fund to be able to provide all the services that is required. But when you have a large pool, which is expected in the health insurance system, then you will have a lot of monies that can be utilized in providing services to the prospective enrollee. That is why we are talking. That's why all the stakeholders in health insurance and in Nigeria are talking government to make the health insurance law mandatory, so that everybody should come on board, and able resources can come into one pool so as to share that risk and the benefit that should be accrued. So it is not surprising that NHIS will develop a benefit package that will not be all-encompassing. If we are to restrict NHIS to be only for the federal government employees, and only the federal government fund is the one that will go into the corpus of the National Health Insurance Scheme.
All right, Dr. Ekpe, let's get your thoughts. You listened to the Vox Pop, what people had to say, and also to what's your experience been like at the Yaya General Hospital? What was your interaction being, having NHIS there?
Well, thank you very much. NHIS is a very good and laudable program for the country, for the Nigerian people. But unfortunately, maybe because of the limited coverage, there's a lot of problem at the provider's end, especially in the public hospitals. Yeah, I just told you, the ES have just mentioned to us that it covers only the federal government employees. So now, if you look at it, majority of patients that are being treated, about 70%, are not federal government employees. These are private sector, private people, that is the informal sector, the communities. So these are the major people that need to be covered, and they're not covered. So if the people who are supposed to be covered are not covered, probably we have to claim the responsibility that it's a failure on the part of government, because they've not done what they have to do for the common people. The people who are working in government have the money to pay, but the individuals who sell akara on the street cannot access care. And these are the real Nigerians that need to be taken care of. So our experience there is that, yes, those who are working with federal government, those who are working with maybe organized private sectors, they get their health bills are covered, or get paid by the NHIS, by the HMOs. But the real people, the gate man, the Merua, whose wife is pregnant, cannot be taken care of. So it boils down to the same thing, that there is a big problem, and that is why, according to the ES, what he said, and the repeal with the presidency, that NHIS should be made mandatory, so that there will be more fund to be able to cater even for the vulnerable and for those who cannot. And of course, we should also look at not just that mandatoriness, but other sorts of fund, because health is wealth. If you have a healthy workforce, the country will move forward. And so we should also begin to look at other points, like 1% from the telecommunication. If it is made for health, that will also be good. Look at, increasing some level of 1% VAT, probably from alcohol, from cigarette smoking, and channel it to health. The only other caveat I will have to say is that we must also make sure how to monitor that huge amount of fund, because it's no gainsaying that there's corruption problem in the country. I think that is all what I would say for now.
But Dr. Ekpe, let's not also forget, just as we said that it's a pool, let's not also forget that there are people who have been contributing that have not had to use the scheme. Well,
you see, like we're saying, people are, he mentioned here, the idea is pooled risk and pooled funds. So the fact that you are contributing does not mean you must mandatorily use the scheme. You have to use it. The fact that I pay for NHI, for insurance health, doesn't mean I'm praying to be sick so that I use it. Let those who are sick should use it. But the more that people comes into it, the more the availability of fund. The fund can even be so much that the man that is lying on the street can be treated. I mean, it's happening in NHS in the UK. It's happening in Europe in different places. You understand? So the basic thing is that limiting the NHIS to just the federal staff worker or organized private sector makes it less than 10% of the population that is being handled. Then what happened to the 90%? That means we are still a sick nation who cannot afford care.
Yeah, Dr. Ekpe, thanks. That's the question I will put to Dr. Kolawole Walker now, who is one of the HMOs. Is the NHIS in coma?
It is not.
Where is it?
Well, I can say, where are we from what we have heard today? They are simply telling us that they want the services. Health is such that everybody needs it. Whether you are the professor, whether you are the gateman, whether you are the merua, everybody needs health. So government has no choice than to follow what the developed world do. And what did they do? They are very simple things. 1883, Germany made it compulsory. 1883, not 1983, not 2003. 1883, Germany made it compulsory. UK made it compulsory 1948. Japan made it compulsory 1922. So Nigeria has no choice. If we really want to give health to our people, make it compulsory. That's number one.
But you have seen what Trump did to Obamacare.
Well, these are things we continue to talk about. Strengthening the health system. I think I get annoyed whenever I see a governor or anybody taking money. Oh, I want to buy bed here. I want to buy. Those are supply side. Supply side will never satisfy us. Look at all our military regimes. When they come in, they tell you, oh, we have a hospital that is now more than a consulting center. And you think that such type of somebody who has taken over, the first thing you should do is make sure that everything is proper. Yes, they will go and do what is called supply side. They will buy bed, they will buy theater, they will reform. No, health has gone beyond that. Health should be a system, and you refine and continue to refine it. And when you get whatever the people who are benefiting tell you, that tells you which buttons you still need to put. So for now, where we are, we need to bring more money into health. We need to bring more people into health. Because in 335 BC, a physician said, when health is absent, wisdom is gone. Intelligence cannot be applied. And strength is helpless. So you see, everybody needs health. We need to divert resources into it, and we need to make sure that we are strengthening it, because we have a system we are following. This is where we are.
Those basic principles, I believe, cannot be disputed, Rhoda, in terms of, health being wealth and the fact that you have to strive to provide for the health of your people. But our specific focus this morning is on the NHIS, that is the National Health Insurance Scheme. Good. And I would like to repeat my question to you on the basis of what we, gather from persons who are enrollees in the scheme, and then when they try to access healthcare, what their experience has also been. What has been the role of the HMOs? Because there are allegations. We've had to discuss this topic on Good Morning Nigeria in the past. There are allegations that the HMOs do not make onward transfers to the healthcare providers.
I think it's hype and a lot of misleading information out there. There are two ways by which HMOs are supposed to pay providers. The first is called capitation. That is the number of enrollees each health facility has. That capitation is per capita, per number of enrollees. It's 750, because now we are all coming together in synergy and opening up everything. I'm supposed to pay you 750 for every enrollee you have. So if you have 1,000 enrollee, that means...
When you say 750, what do you mean?
750 naira.
For one enrollee?
For one enrollee.
For a month?
For a month, yeah.
You pay for what? Is it for consultation, for medication?
Drugs?
Very good. We call it capitation, to take care of primary services.
Namely?
Namely, anything that you don't need to refer or you don't need to be admitted, that is not in the benefit package that shows enlarged services for referral.
750.
750. So
wow.
You see
that's
that
the cost of a recharge card.
that is why one of the things we are also talking is it is all the stakeholders that need to sit together and see how they can increase the tariff and know how they can. And that is just for capitation, to take care of primary services.
Well, when you
if
say
you are
primary
referred,
service, sorry, when you say primary service, does that include if you have to, like you said, you're not on admission, but includes blood test?
A little of it, not detailed blood tests, maybe just hemoglobin and PCV. Not detailed serum blood analysis. That will be when you are referred to a secondary center.
My question is this now. What is your role? Because we're going to really drill into this. What is your role as let's get your role as an HMO. What role do you play in this chain?
Our major role is to make sure that there is quality of health services in those hospitals. Okay. So that is why some money is paid to us to be given to them. Okay. And there are two ways by which we pay them. The first way is what I've told you, capitation. When I was president of IMCAN, I made sure that that capitation was paid 100%, and we have proofs for it. So anybody who says they are owing him capitation today should please raise the flag. Nobody is owing capitation as I'm sitting down talking to you, even now. Then the second payment is called fee for service, and this is where the drama is. That you are just telling me that 750 is small for capitation. Do you know how much they pay for enrollee for fee for service? 112 naira 50 kobo. So if you are admitted,
what does that cover?
Very good. That is supposed to cover if you are admitted or you have serious operations or anything. 112 naira 50 kobo.
Look, Dr. Ekpa, is this a joke or something?
No, well, I think...
I mean, we just say, because when you look at these numbers and you look at the economic realities,
you are not getting it right. Yes. Let's get it this way.
Yeah.
1 million persons pay 750 naira. That is 750,000 naira. At the end of the day, maybe about 100,000 persons comes to access the care. So that 750 million is now used to treat the 100,000 persons. So it's not about, if you look at it one-on-one, it sounds very unrealistic. But this is insurance. So we're looking about pools and the number. You know, I mean, there are even some states or some countries that are paying less than that. But because a large number is covered, that money is enough to take. You see, like we're all here. It's not everybody here that's going to be sick in the next 1 month. Probably 1 or 2 persons. And if all of us contribute and that money is used for that particular person, the money is enough. So it's not necessarily about the amount, but it's about the number of coverage.
Which numbers are we talking about, Dr. Ekpe?
The population.
Just hold on a second. Let me frame my question so you can respond. He said 750 naira for capitation per enrollee.
Yes.
We're not talking about the number of enrollees at Yaya Hospital. We're talking about enrollees throughout the federation who are federal government workers registered for the scheme.
Yes, sir.
Yes?
I'll answer you.
Yes.
It's not all the federal government workers that are going to the hospital to access treatment. True. But it's all of them that are paying 750 per month. So let's say the federal government workers are 100,000 times 750. And at the end of the month, probably about 10,000, if you work out the actuarial, he knows better, that says that means money meant for 100,000 persons is used to treat 10,000 persons.
Okay.
Do you understand what I'm trying to say? Yeah. So that is the point. That is what insurance actually means.
Yeah, hang on again. Sorry, let's have this as a conversation. But we know the disease burden in Nigeria.
No, I agree with you.
Is it realistic?
I'm not trying to run away from the fact that, I mean, that money is small as of this moment. Remember, too, that, I mean, these decisions were, like the last increment was 2012, right?
Yeah,
yes, 2012. That's 750. It's time to review it probably to up to 2,000 or 1,500. Yeah. But I'm just trying to make it clear that we shouldn't compare it one-on-one, because even when you say for enrollee to pay 2,000, even 5,000 per month, if you make it one person, say, okay, for your treatment per month, for you particularly, you know, that is 5,000 per you. I mean, it sounds unrealistic. But when you pool the number, which is the whole aim of insurance, then you have enough to treat the percentage that is most likely going to be. Remember that the percentage that is going to be sick are usually far less than than 50%.
Yet,
yes.
That theoretically now,
yes.
And yet, the complaints we are having reflect a shabby treatment of patients. Some of them will complain that if you once you go to a healthcare provider and they see that you are from NHIS, you are almost treated like a second-class citizen.
Yes, and
some of them, they say the quality of drugs that they are given are usually either generic or non-branded drugs. You don't get the quality of healthcare that you need. That's the complaint.
So the reason is that because there is poor management of the system, both from I don't want to look at it from NHIS level. I want to look at it probably from HMO level to the providers level. Why did I say that? First of all, majority of the hospitals who are supposed to do secondary care and tertiary care are doing primary care. Now, the more enrollee you have, the more availability of fund for you to offer quality care to patient. But if you have less enrollee, then you are tired, you cannot do so much. And you find that, and once you are spending more in treating the patient, you are in business. Health is also part of business. It's not necessary, it's not free. Even if it's a social system that has to be supported, it's not free. So when an NHIS patient comes to an hospital that is poorly funded in terms of insurance funds, definitely they're going to be under treatment. That is just usually what happens sometimes. Then the other issue is that the populace also need to understand what it means. For instance, I think there are some care that is not covered. So if you get in there because you felt you have paid for insurance and they tell you it's not covered, they get angry and they say the wrong statement. But I'll tell you, I'm in Nana General Hospital. Those who are entitled to health insurance, they get it and they're happy, and it's a saving grace actually for some of them. So it is what we should encourage, increase the population enrollee, make it mandatory, and then the workability is also very, very important. And that is why they do the training of providers to understand how insurance work, so that it will be seamless, because quite a lot of times, a lot of bottlenecks. For instance, you may have to make some calls to get a code to be sure that this person is covered, to be sure that this person is paid. All those are some delays.
That's an issue we're going to really, because I've seen instances where somebody needed an emergency CS, and there we were trying to call, get NHIS, trying to get a code, and that took almost a whole day. Those are some of the bottlenecks that we'll talk about. But then I'd like the CEO to come in, Dr. Sambo. What's your take on this?
Yeah. Thank you very much. I think people need to understand the underpinning principle and philosophy behind the health insurance. As rightly pointed out by my colleague here, the health insurance survives on pooling. When we say 750 naira, we don't mean that you pay 750 naira and you get all the services you require. If 1,000 people pool, we pool 750 from 1,000 people. The epidemiological trend, what I mean, the frequency of diseases in human population don't occur at the same time. You don't have people having malaria, all the enrollees having malaria at the same time. Or you don't have all the people that have contributed having appendicitis at the same time. You have all contributed for this month. And some proportion of the contributors will get malaria. Some proportion will get appendix. Some appendicitis. Some proportion will get typhoid fever. So if you have done a very good actuary, you will have a good idea of what is the trend of diseases in your own population and how much is a unit cost to cater for that. So once you have your actuary, you will have a contribution based on that actuary that will cover the disease profile that is happening in that community. So it is not done by offhead. It is done based on data, where you have a data that shows the risk of the occurrence of diseases and how much is it to cater for those diseases. So if you have an actuary that is well calculated, people will be coming to the healthcare facilities. You may even have a situation whereby somebody who has contributed for 1 year, he has not had any cost to seek for that treatment. But his own contribution will be used by somebody who is sick. That is why we must understand this concept if we are to understand the way and manner national health insurance schemes work. So by the time you have that actuary, you will cover population without any hitch. But if you look at the contribution from the workers, with very meager minimum wage. You cannot get all the 100% of his salary and say this is a contribution for health insurance. You have to take the proportion of that small amount to put it in the pool. So when you put it in the pool, the actuarial scientists will tell you that the amount so accumulated will be able to cover this number of benefit package. Then coming to the issue of capitation, when you pay a capitation, the whole idea, there are so many ways you reimburse healthcare providers in health insurance, either through capitation or through fee for service or through other means. There is what is called per diem, P package, and so on and so forth. The whole idea of giving a primary healthcare provider capitation is to ensure that based on the number of people that have been earmarked for that healthcare facility, they will go and seek for services. And primary healthcare services, including malarial treatment and basic diseases that are treated under primary healthcare, will be provided to them. And after that primary healthcare services, they will be referred. So in the primary healthcare, we don't normally receive complaints with respect to capitation, but we do receive a lot of problems with respect to fee for service. And that is why that is where we are working in health insurance to ensure that those complaints that we receive, we have taken care of them. Let me give you an instance. The guideline of National Health Insurance says if you are to be referred to a secondary healthcare facility, you need to obtain a code from the health maintenance organizations, and you need to get that code within 24 hours. If you get that code, you now move to the secondary healthcare facility. If you don't get that code, you cannot move to secondary healthcare facility. I think when I was reviewing this guideline with my staff, I realized that there is a lot of lacuna in this situation. How can somebody, a patient, be waiting for 24 hours to be referred into secondary healthcare facilities? So the proposal that we are putting on table now is that if you are to be referred, HMO will be notified, and within 6 hours, HMO must give a code. If HMO is not able to give the code, you call NHIS center, we will give you a code, we will generate a code for you to go and seek for healthcare services. And since we are the people that are paying the HMOs, we will ensure that that money, that facility is reimbursed for giving you services. These are some of the modifications that we are trying to bring up in health insurance.
Who regulates, supervises the HMOs?
National Health Insurance Scheme.
Okay.
My colleagues say that there is no problem with National Health Insurance Scheme. I don't believe so. I am 80 days in the National Health Insurance Scheme, and I know that the capacity of NHIS to regulate activity is very, very weak. That is why even when HMOs do add, you can hardly bring them to book. And this is not unconnected with the current structure of the National Health Insurance Scheme. You have a scheme with 103,000 people. 40% of those staff are residing in the headquarters. Only 60% are scattered across the 36 states and Federal Republic of Nigeria. And if you look at the activities of the National Health Insurance Scheme, accreditation is to be conducted, supervision is to be conducted, reconciliation is to be conducted, quality assurance is to be guaranteed, and all these things are not taking place. Or some of them are taking place, but very irregularly. Because when you have a situation whereby you expect people from the headquarters of the National Health Insurance Scheme to go to Lagos, to go to Ebonyi, to go to Zaria, to go to Kaduna, and regulate activities, that is not going to work. So the regulatory function of the health insurance as currently established is not designed to work.
In fact, Professor Mohammed Sambo, thank you very much for what you have said. If you have 40% or more of your staff at the headquarters, and they have to supervise the outlying locations, that is the way the public service works. Because when they travel, they will get DTA, duty toll allowance, and then that fattens their pocket.
Absolutely.
And so on and so forth. But even more connected to what you are saying, Is the NHIS structured as a business, or is it just structured as another parastatal? You've been talking about actuary. I mean, that's the foundation of actuarial science. You know, for you to make forecasts as to, you know, human beings, life of human beings and occurrences and so on and so forth. Elsewhere, where the health insurance scheme works, you have accountants, you have business managers, you have actuaries, you know, who are all involved in all of this. How much of this kind of personnel do you have in your system, and how well equipped are they to function?
This is a very tough one, but I will attempt to answer it. At the time when the National Health Insurance Scheme started, you don't have the mixture of the kind of human resource that is required to drive the National Health Insurance Scheme. So many people were brought in. But when they were brought in, the level of capacity building that took place was very weak. And that is why the organization is weak, and that's exactly what we are trying to do in the National Health Insurance Scheme now, to be able to strengthen. When I'm appointed in the last three months, I came up with agenda of rebranding the organization, which is anchored on 3 pillars. Number 1, value reorientation, in order to strengthen the organization to be credible, to be able to perform its stewardship function. Number 2, to engender transparency and accountability in the entire operation of the scheme, right from the level of the National Health Insurance Scheme to the level of recipient that is also prone to, susceptible to defrauding the scheme. So if we don't have that value chain of transparency and accountability, we should forget having a very good health insurance. And number 3, to accelerate drive towards realizing the health for all by the year 2030, which is a presidential mandate, which is a mandate of the Sustainable Development Goals. Yes, ma'am.
I'll come back to you, but very briefly, I'd like Dr. Oka to also come in here. Is the HMO in charge of getting drugs, drips, injections? Who's in charge of that? Who does that?
Providers. Healthcare facilities.
So who regulates the quality of drugs that they bring in?
Okay, let me quickly mention what he said, that we are using generic drug. We need to let people know that generic drug does not mean that they are inferior. They are not. They do the same thing. And it is an international standard to use generic drugs. It's not just in Nigeria. Our job is to visit those providers and see that what they are giving out to people is the correct drugs.
Okay.
We do that.
How often do you do that?
Oh, we even send, once we know that somebody is admitted, we have nurses, we call them concurrent utilization nurses, who visit them on the bed, who visit them during the... We even have some people that we place on major hospitals like National Hospital, Federal Medical Center, and so on. We have them there. And if you look at some HMOs, many of these centers, apart from having people there, we even give them free telephone to call,
but
so that they can always reach us.
See,
have you been aware?
Rhoda, I just wonder, the same question I asked Professor Samba, I'd like to ask Dr. Kolawole.
Yeah.
What is the capacity of your own personnel, even as an HMO? Do you also have your business managers? Do you have your actuary experts? Do you, because it's a total package.
Yeah, we are a private organization.
Just hang on a second. Earlier you were talking about Japan, Norway, Germany. You excluded the US, but of course I reminded you. But elsewhere where these things work, you will see the number of professionals from a broad range of fields, mostly business, of course, including medical personnel, the finance experts, and so on and so forth, even working in HMOs. What level of capacity of staffing do you have?
We have all those, I can assure you.
So how come we are having these challenges of you paying providers?
That is what I'm saying. I was trying to explain to you, there are 2 forms of payment. There's nobody is having any challenge about capitation payment. That is 100% paid, and I'm sure he can attest to it from what he has. But it could be better when NHIS embarks on what is called a robust IT. With that robust IT, he can sit in his office and monitor, just as the CBN can monitor all the commercial banks. He can sit in his office and monitor everybody, the HMO, the providers, and even so that he knows how the money moves. That's number one. The fee for service, we all need to sit down together and say, look, this fee for service, they need to increase the money. That's number one. Then number two, we need to let them know, especially the providers, that those days when a provider thinks he can write any bill and get it is over. Nowadays, any bill a provider writes, you have to look at the tariff, whether it obeys the tariff or not. Then two, you have to look at the pool, how much is restricted for that. Because if we are not watching the pool, it will burst. So our job is not just looking at that quality, we are also looking at cost containment. And we are also looking at customer satisfaction, whether the enrollee is satisfied or not. And that is why I said at the beginning that we have started a system. We all need to sit down and see how do we strengthen that system so that all the processes can be better. Because what the enrollees are saying is that they are not enjoying some of the processes.
Not some.
No, not just some.
There's dissatisfaction.
I say this
Good.
because
so
you
it's
were saying
our job, all of us,
We've
to
been
sit
doing
down.
this. We've been on this now.
how-
It's been effective since 2005.
Yeah.
That's 14 years. But in a few months, we'll be into the 15th year. And by the way, as a provider, has anybody sued you, for?
Well, no, not really, but like I see a lot of complaint. Let me just correct an impression. There could be problem at the policy level of NHIS, and there could be problem at the logistic level. But what I said is that for those patients who are able to access NHIS and get treated, they have that level of satisfaction. That's who just go through it. For instance, maybe somebody who comes to do antenatal eventually gets elective cesarean section done. It's all well and okay. But of course, there are a myriad of problems in the bottleneck of payment and payment of capitation and also payment of fee for service. One of the biggest problems I must tell you is that it appears NHIS is just meant for public service and meant for government hospitals. So if a private hospital takes up NHIS program, it's not going to work. Why? Because government has already subsidized health at the public sector. They pay the salaries. They pay for accommodation. They pay for a lot of utilities and rest of them. So those government hospitals are able to manage. However, if you take the same cost to a private hospital, it's not possible. And that is why in private hospitals, if you're NHIS insured, many private hospitals do not want to even confirm with NHIS. Many of them.
I say this because you said earlier that at least for those who go for primary health care, like, you have malaria, you have typhoid, those are basic, it's not everyone that is admitted every month.
Yes.
But then he said that you provide, the hospital provides the drugs.
Yes.
I'm sure you've heard of issues where you have certain drugs not being available under NHIS.
Yes.
Why is this? So what is it with this particular drug is not under NHIS? Or if it is under NHIS, it is the generic one, you cannot access the branded one?
Well, the way I look at it is that when you look at the hospital, it is not just about the NHIS patient alone. It's about the general patient that comes to the hospital. And there's no drug kept aside, one place for NHIS patient, and then another one for these other persons. They're all kept in the same place. Generic drugs are cheaper, but they are still effective. It's just that you have to be careful because a lot of generic drugs are also not working. He will agree with me.
Okay.
Yes, you see,
That's
a lot
the
of
point. But he was talking
Yes.
about international standard.
yes, there are a lot of generic drugs
standard.
not working, and we are the providers, and there are situations you actually have to go to a branded drug.
And so
for
the
you to
patient
get
has to
effective.
go and buy that drug
Well,
outside.
In that case, yeah, because NHIS have put a rule, because of also the limitation of fund we are talking about. You pay for things. A branded drug is costing 4,000. The generic is costing 800 naira. Do you understand what I say? So with the bigger amount of money that is involved, it can only afford 800. It's just like saying you want to go to the airport. Instead of using a normal good taxi, you decide to use a jeep. You understand what I say? That is the difference. That is the difference between branded drug and generic drug. But again, the generic drug, there are quite a lot of them that are not okay. So it also reduces the quality of care.
Yeah.
But the other thing I'm saying, sir,
Yes.
is that the system, general health system in the country is also affecting the NHIS. You understand me, sir?
No, I don't understand.
What I mean is that for instance, even small issues like what is the budget for health in the country? How much is being put into health system management in the country? It's affecting everywhere.
But that's well and good, but we're just taking a slice of it
Yes.
now. I mean, you say health system.
No, because he asked a question that how come for an NHIS enrollee maybe need to access a particular drug and it's not available.
Yeah.
Because the drug there is not just used for only NHS enrollee, it's used for everybody. And so at that point in time, sometimes it's not available. And again, the issue of fee for service that he has mentioned is so small, it's so meager. And when you consume such a drug too, you know, it makes it not available because you're spending much more on a very small amount of premium.
Dr. Ekpe,
Yes.
thank you very much. I'm happy you referred to the healthcare system in the country.
Yes.
A system has component parts.
Yes.
It's one component part that we are discussing now,
agree, sir.
which is NHIS. And the ES, you know, has very rightly, along with the other guys, put his finger on what some of the core problems are. You can look at it if from the root of NHIS, how it was conceptualized, configured, and then made to function.
Yeah.
You just have persons who have jobs, but probably not cognate experience required to drive this kind of health insurance scheme. We have already tweets that have come in from our viewers. We take those tweets now and you know, continue with the conversation. Ahmadu Mangai tweets, the NHIS scheme, well, NHIS is a scheme. It's a laudable program that has a lot of benefits. Unfortunately, the implementation of the program is staggered, as only federal government workers seem to be the major beneficiaries. The scheme should be made all-inclusive and publicized adequately.
And this one is from Solomon. He says the scheme will go a long way to help Nigerians if properly harnessed. Many people do not know importance of the scheme. I believe more orientation needs to be done, especially to the people at the rural areas. Thank you very much for bringing up this topic at this time.
Now, Utulo Sunday, the scheme will go a long way in helping many Nigerians if properly harnessed. Many people do not know the importance of the scheme. I believe more orientation needs to be done, especially to the people in the rural areas.
Mike Anyoku says, for federal civil servants, the NHIS is best. My humble self and my family are accessing it through my wife, a civil servant. The big question is, how about healthcare for every citizen of the country? How about delays in settling primary providers of NHS?
Now, Comrade Dungala tweets, why is it that the health insurance scheme is only benefited by federal government workers? Because they are the ones who are contributing now.
And
all right, I'm just wondering, Francis Obi, that's the next one.
okay, he says, I believe the full implementation has dragged, even though the scheme is very good. It should be taken to both states and local governments.
Abbas Abubakar Saad. Now, this has to do with making health service available to families across the nation. But unfortunately, many families don't access it due to the fact that there is no adequate sensitization about it. On the part of government, budgetary allocation and releases to health are not adequate.
The late Jack Solomon says NHIS is, as an implementing a regulatory organization, has also suffered from ineffective leadership, lack of succession plan, and a poor governance structure over the years. That's why investment in the scheme has not resulted in equitable access to healthcare and improved outcomes.
Sadly, just like it bedevils many of our national life, corruption in NHIS is threatening seriously the efficacy of the scheme. Providers, especially at the primary healthcare level, are often not paid. That's a big blow to the scheme survival.
All right, this one is from Abdul. He says the scheme is laudable, but the implementation has been hampered by widespread corruption. Those providers responsible for its implementation have not lived up to expectations. They cut corners, hence only a few benefit from the scheme. Complete overhauling is needed.
Law Alpha say many Nigerian workers and citizens alike are not abreast of the workings and modus operandi of this very important scheme. So effective sensitization and consultations are urgently needed to carry along all classes of the Nigerian populace.
And this one is from Sani Michael Omakaji. Says, ideally the scheme is supposed to be a benefit to civil servants, but the current situation that the federal workers are in priority list to the disadvantage of state and local government workers is unacceptable. Perhaps there's need for the scheme to be restructured for all workers' benefit.
Professor Sambo.
Thank you very much. because the conversation starts with the problem of the enrollees. That's why I think the whole discussion is not flowing the way it should. But let me quickly tell you that the health insurance started with the federal government employees. When it was realized that it is a very good scheme and it needs expansion, the law of the National Health Insurance Scheme was targeting formal sector only, and organized private sector. There was a struggle or a momentum some years back, more than a decade, where there will be a National Health Act. That National Health Act was to serve as a tool that will bring more resources to the healthcare delivery system. And the National Health Act was passed into law in 2004. And by last year, 2014, by last year, government, under the law, under the act, 1% of monies from consolidated revenue account will come to the healthcare delivery system. And half of it will go to the National Health Insurance Scheme. And another half, part of it will go to the National Primary Healthcare Development Agency. Some proportion will go to the emergency healthcare services. So there are three gateways to the basic healthcare provision funds. And from that 1% consolidated revenue, monies are supposed to, the monies that is coming to the National Health Insurance Scheme will go to the states. And each state was expected to establish a state health insurance scheme so that they will serve as a catalyst for driving and expanding coverage for the National Health Insurance Scheme. This year, federal government has been able to release about 13.5 billion naira, which is unprecedented in the healthcare delivery system. Half of it has come to the National Health Insurance Scheme, which is the first tranche. And we have disbursed it to all the states that have fulfilled the criteria. The expectation is that every state health insurance scheme should have a program for the formal sector employees at the state level and at the local government level. Then the monies that is coming from the basic healthcare fund will now be used in covering the vulnerable segment of the population. Last month, the Honorable Minister, we celebrated the first disbursement of the first tranche, whereby the Honorable Minister had a press conference with pressmen for the disbursement of the funds. So a lot is being done by the federal government in collaboration with the state.
How many states have their own health insurance schemes? And there are scattered reports from time to time as to which state has launched what.
For now, as at now, every state has its own health insurance.
Every state?
Every state. In fact, if you go to Kano State, they have even commenced the formal sector social health insurance program. If you go to Lagos, they have commenced the formal sector social health insurance program. So the condition that a state must fulfill to get the monies from the federal government is that they must have the social state health insurance fund. So even those states that were dragging their feet, they are now trying to dot all the I's and cross all the T's to ensure that those their health insurance are on ground. We have disbursed monies for the states that have fulfilled all the criteria as at February, because the money was released in May and we have been able to disburse them. And many states were calling us, why is it that their states are not there? We told them the guideline for the disbursement is very clear. In fact, I have been seeing many states coming to the health insurance scheme to ensure that they did not miss the second tranche. How
will the state health insurance scheme work at the subnational level?
Excellent. The state health insurance scheme will have to cover the formal sector within the state and local government. There should be a budgetary allocation provision for the 10% of their salary by the states and the local government, so that just like what is happening by the federal government workers, the state will now provide care for the employees of the state. Then the monies that is coming to the basic healthcare trust fund, it will be used to cover the vulnerable segment of the population, the aged, who are above 65 years, the women, the pregnant women, the children under 5, and people with disability. So by the time those states are fully on board, and you now have this program for them, Nigeria will be talking about acceleration of
Doctor,
universal coverage.
Are the HMOs in liaison with the state health insurance schemes, or they have a new mechanism for operating their own scheme?
Why not? How
is it working out?
Well, they have been slow about it, but I think they are supposed to follow the same path just as the NHIS is doing.
No, there's modification as to where the state will have to operate their own health insurance. The state have options, whether to utilize HMO as a middleman or not. Some states will opt to directly reimburse the healthcare facilities within their states. And states, if they like, they can use HMO as a middleman to do it. So you will see a variant method of application at the state level. It is not compulsory, just like in the National Health Insurance Scheme as provided by the Act, that we have to use the health maintenance organization. But at state level, their laws are flexible. They can either utilize the services of health maintenance organization, or they can administer it wholly. That's the modus operandi.
As it stands now, the HMO is like an intermediary between you and the enrollees.
Yes.
What mechanisms do you have in place to measure their performance, especially through the eyes of the enrollees? How do you get feedback from enrollees to say, okay, I'm not getting an appropriate care? And another question I wanted to ask you is this. When we have pension schemes as civil servants, we're able to choose what pension, pension manager that we want. And if we're not satisfied, probably we could change to another pension manager. Why is it that with NHIS you can't choose your HMO?
Thank you very much. The initial concept of NHIS, frankly speaking, does not provide that HMO should be allocated to the MDS.
Okay.
And in fact, that is one of the major problems that we have in the industry, whereby HMO will go and meet an MDA and get all the employees to be registered with them. That in the spirit, it has not provided the spirit of competitiveness.
Yeah.
And these are the issues that we must have to address in the operations of National Health Insurance Scheme if we are to get it right. Under the new NHIS, we want to see a situation whereby if we have a robust ICT, we will have a situation whereby an employee will just log into his handset and be able to select his own provider and select his HMO. If he's not satisfied, he migrates to another HMO. That will bring about competitiveness, and that will solve a lot of problems that is happening in the health insurance. We should not pretend that there are no problems. There are myriads of problems.
Absolutely.
And in the new NHIS, we are getting to the bottom of everything to ensure that we bring out the problems. That is why in the last 80 days we have spent in the National Health Insurance Scheme, we organized a stakeholders meeting with enrollees, where we harness all the challenges they are facing in the process of receiving healthcare services. We also had a stakeholders engagement with providers. We harness all their problems. We had an engagement with health maintenance organizations. We also harnessed and presented all the problems that is happening. Then the last engagement we had was the State Health Insurance Board, so that we also position them to be able to take care of their state health insurance. Immediately after this engagement, at the level of NHIS, we sat down to analyze all these problems and develop strategy to combat the problems. One of the problems, as you mentioned earlier, is that HMO will be called. For 24 hours, he will not be available.
That's right.
Yeah.
And as if NHIS is to perform its regulatory function, they must put a mechanism to address it. That's why I say in our management meeting, we have agreed to modify that provision of the guideline. Within 6 months,
6 hours.
within 6 hours, you must be able to provide a code, to authorization code for any patient that is being referred. And if you cannot get that code, NHIS will supply the code and ensure that it deducts whatever is payable to the healthcare provider that the services has been utilized. Secondly, as I said, 40% of the workers of NHIS are in headquarters, just awaiting, just doing nothing. Meanwhile, there is a lot of work to be done at the state level. So what we are trying to do is to see how we can strengthen our zonal office, our state offices, and elevate them to a directorate level, so that accreditation can be done at that level, inspection can be done at that level, reconciliation will be done at that level, quality assurance will be done at that level. If there are complaints, now what is happening in health insurance? If there is a complaint with Eroli in, say, Kauranamo, the local government, it will come to the headquarters.
Okay, how are you doing that?
I can't understand.
Yeah. I'm just wondering, Professor Sambo, very quick, how many HMOs are you dealing with at the moment?
We have
and have you sanctioned them? I mean, if there's a breach.
We have about 56 HMO that are accredited. The NHIS must perform its regulatory function if this scheme should work. And when I came to NHIS and looked at the sanctions, I realized that it's watered. No sanctions. People are just operating without sanctions. And in the interaction with the HMO, one HMO, he made mention that unless if we go according to the books, we will not be able to get it. And according to our books, there are provision for sanctions. And these sanctions are not being meted on the hiring HMO or hiring providers. In fact, NHIS has its own problem. And if we try to bury the problem, we will not be able to get the solution. One of the problems that NHIS has, I will tell you, the payment system, when hitherto, it used to be on quarterly basis. You pay HMO on quarterly basis in advance, so that by the end of the month, they can be able to pay all the providers. And when the enrollees go to look for services, they will not be denied services. Somehow, that payment system was changed. Then NHIS now changed it to monthly basis. And you realize that when I am going through the book, I realize that payment on monthly basis is not sustainable, because there could be a delay on the part of the National Health Insurance Scheme, and that will affect the HMO. And once HMO has not getting the monies, he will not give to the healthcare providers, and the clients that will go in the first week or second week, they will be returned. That monies for capitation has not been paid. So what we are trying to do, we look at that problem, and we have developed a solution to that. We will revert to the quarterly payment and ensure that we give the HMOs, and we tighten our control mechanism, so that any hiring HMO, we have given you monies, we have given you monies, and you could not pay a facility, then you are entitled to
just
sanction.
very briefly, I just want to ask you, why does it take up to 4 months to change your health institution? Why?
I see no reason for that.
4 months, that is okay. I need a pediatrician. Okay, I'm using a healthcare where you don't they tell you, oh, the pediatrician we have is no longer here, and so I need a pediatrician. I say, okay, I want to change my health facility.
Yes.
It takes about 4 to 5 months to do that.
These are some of the things that, to my mind, are detrimental to the National Health Insurance Scheme. If we have a mechanism whereby people can switch, but in switching, you see all these things that we are talking, by the time we have ICT-driven NHIS, which we are working very hard to get it, it will be a thing of the past. Because changing, maybe you are an enrollee from a far distance, it will take the NHIS state offices are not functioning. Things have to go to the federal level for you to be able to get that. It's very difficult. But now if we strengthen our state offices, and if you have a complaint, you can get into the state office and your complaint will be addressed. There is no reason why somebody will spend 4 months wanting to change his provider.
Professor Sambo, very quickly, the monies that NHIS is wiring to the state health insurance schemes, who monitors the utilization to be sure that indeed that is where the money is going for? Because we have seen federation account money goes to the local governments, and we have seen what has happened to local governments in this country.
Yeah, there are multi-layer process of monitoring. First of all, NHIS is interfacing with the state health insurance. We send monies, and part of the monies, there are monies that are dedicated for monitoring and evaluation. And at the national level, there is a steering committee which look at what is happening in the national health insurance at the state. But the most important, as I said, if we don't have a very strong state offices who will be checking the activities of health insurance activities at state level, we will not get there.
All right, let's get the closing thoughts of Dr. Ekme.
All right, thank you very much. Maybe I'll look at it from both angles, from providers' end and NMA's end. As providers, we hope that there will be the health insurance should be mandatory, so that all Nigerians are covered. And at NMA's level, we are looking at universal health coverage. It's only with mandatory health insurance that we're going to be able to achieve some level of universal health coverage. And we're saying that the federal government should increase the budget to health. You know, they're doing, but it's not enough. They should do more to increase the budget for health.
Yeah.
Thank
Dr.
you.
Uwoka.
Yeah, thank you for this message, because we want a lot of awareness created. Let people know their responsibilities. When you mentioned about customer satisfaction, I need to let you know that HMOs, we have offices all over the states, all over the country, so that any enrollee that can get their customer satisfaction from the HMOs. What we also believe is this: a system has been started. Let us strengthen that system so that all the processes that are having one each or the other we can make it better.
All right,
to achieve universal health coverage.
Thank you very much. It's on that note we want to thank Dr. Kolawole Owoka. He's the Managing Director and Chief Executive Officer of United Healthcare International. Thank you very much for coming on the program.
Thank you.
And also a very big thank you to Dr. Philip Uche Ekme. He's the Chairman at MAFCT and the MD Yaya General Hospital. Thank you for coming.
Thank you.
And a very big thank you to Professor Mohammed Nasiru Sambo. He's the Executive Secretary and CEO of the NHIS. Thank you for your thoughts and time on the program this morning.
Thank you very much.
All right, up next is sports.